a better job, and I'm not here, it's not actually a debate. I do exactly the same thing what he says for most of the routine detachments with peripheral breaks, but the indications for vitrectomy are increasing by the day. We are tending to do more vitrectomies than what we would do for buckling in certain given situations, and of course the indications have also changed. So has the technology changed, which is also compelling us. It's become safer, better since a long time what used to be before, as in terms of vitrectomy. So a lot of conceptual change has been happening, but this is not really a debate on buckling versus vitrectomy, and that's what I want to clarify, because we do exactly the same buckling methodology what he does for the peripheral breaks or inferior breaks, young patients with phakic eyes where you don't want a vitrectomy to be done. This is financial disclosure for some of the travel grants or honorariums I've received over this year. A few quick clips to show you before I go on to the videos as to why the technology is compelling us now. Is because the safety of vitrectomy surgery has gone up leaps and bounds. Now the cutters or the dynamics, the fluidics, what we used to deal with even 5 years back has changed totally. The safety issues which used to be there with lower cutting based cutting technology is more or less gone. You have cutters which are cutting at 5,000 cuts a minute, and very soon they'll be going up to 7,500 or 10,000 cuts. And that's changed a lot as to what the way the dynamics of the ports which are structured have changed, the way the fluidics governing these situations have changed. You can see also a concept of duty cycle, which means that the same cutting, two different cutters at the same cut rate could be actually aspirating a little more or a little less just by changing duty cycle, and that's something unique to the technology which is available now. So you can see that both are cutting at the same speed of 2,500, but one keeps the mouth open a little longer as compared to the other, which allows this to take in more as compared to this. So if you want safety, you'll be working at this mode. If you want more activity happening at the core area, which is away from the periphery, you would be looking at this area. So when you look at this situation and then go on to your surgery, you can see the advantage. Now when you are looking at a detachment with these multiple breaks, you have blood admixed with vitreous which is touching the edges of the breaks and is attached. There's nothing better than going in and actually cleaning them up with technology which is available to you, which is on a high speed cut rate which could be controlled at about 5,000 cuts a minute. You're working at 25 or 23 gauge cutters which have extremely small bore which hardly allow anything other than what you want to go inside those ports. So this was not there before, and that's why we are getting more and more confident with what we do inside and also cause less damage in that process. Now this is an example of a failed buckle. A patient has undergone a buckling surgery, but for some reason has failed. Now there is nothing better than going with the small gauge. You already have a buckled conjunctiva. Now you go in second time. It's so much easier. Instead of trying to go and shift the buckle or go and do different maneuvers, open the conjunctiva, it makes your job much simpler. You go in with 25 gauge. You don't even open the conjunctiva. Clean up the vitreous which is there, and then identify the break which are somewhere here. You can see this is at the posterior part of the buccal area which has opened up. So for whatever reason it has failed, and then you do an air fluid exchange. After that go in and do endo drainage with a soft tip cannula. This whole thing hardly takes 15-20 minutes because of the speed of removal of vitrectomy with these cutter, the speeds, and it's a very nice procedure from the patient's perspective, who in their terms is undergoing a second surgery because of a failed procedure. The laser is also has to be done, of course, to the areas concerned. These are of course large inferior breaks, young patient, you have vitreous which is extremely adherent and a stiff inferior retina. Now here you would need, once you are planning a vitrectomy, you need a combined procedure. So in such cases I would not do just a vitrectomy, I would put an encircling buckle so that it supports the periphery. So in this case, as you would see, we are doing a 20 gauge approach because I already opened the conjunctiva for a buckle, so might as well use that. that, but even with 20 gauge you can actually use the advantages of fast cutting as well as the fluidics advantages that we discussed. So here the problem is the hyaloid. You can see how stiff the hyaloid is. You can see the glistening the hyaloid which is attached. So just to stabilize the posterior pole, we go in and put some perfluorocarbon so that we are not messing up with the posterior pole while making all these maneuvers on the hyaloid. And then slowly try and pull it as much as possible in a gentle way, and also keep kind of segmenting it, because you know that at some point when you are pulling, if beyond that point you might actually bring about a dialysis or a tear in the periphery if you just go on, because some of the time the vitreous is extremely adherent. So you pull it under visibility. The wide field visualization allows you to see extreme periphery and keep a watch on it, so that you don't actually pull beyond what is required. And once you make a call that okay, I've pulled enough and I might get a tear, you start cutting. And actually, so you keep segmenting and cutting and aspirating, and at some point you will see the hyaloid giving way. But in young patients, at times you might still be left with some hyaloid which you would just need to kind of minimally clear off and shave it right to the rim and still leave it, because there's no way you can always remove everything. As you can see here, we are struggling to get that whole sheet off. We've gotten it off the posterior pole, but the extreme periphery is difficult, and you can see how much of a tussle it is, and this is what can bring about tears and breaks. And so you need to be working on wide field visualizing systems, which is a must to prevent these problems. So at some point we've been able to relax it. You can see the buccal below, which is now well supporting the tears, which look pretty stiff at the beginning, and we've removed enough vitreous to flatten it, and then of course we make sure we do a good laser all around in these cases. This is another situation where you have inferior breaks and also have PVR changes which have become a few small puckers. This is actually an old prophylaxis done patient which had already underwent some laser in the past but has now given way and has caused this. So here your aim is to clean up as much as possible. You also see a bit of puckering in this area, so you need to make sure that you remove it, because these are situations which would lead to recurrence of PVR. So here we in a mobile retina, it's always good to peel under heavy liquids because you have better control. Otherwise the retina keeps pulling onto itself and you might not get a good feel or hold on it, unlike when you're peeling a membrane in a flat retina patient of a macular hole or a macular pucker. Now there are situations where you would do a primary vitrectomy for a superior RD for a macula on RD. Now this is a nasal RD for which it's a pseudophakic patient who's come with a fresh RD creeping nasally, and there are multiple breaks. There's actually also one inferior you'll see during the course, but there are about 3 breaks here. And in these situations, I think it's ideal that as soon as you finish a core, I would like to put a bubble of PFCL on the macula, because at no point do I want the macula to come off. There's an inferior break somewhere here as well. So here I think you need to use heavy liquids for the purpose of saving it from detaching, because we know that when we do air fluid exchange, the bullas come up, and at times a flat macula could actually kind of just elevate because of air fluid exchange, and you don't want that elevation to happen at times. This is another situation. I'm just trying to show you a small problem which can occur. Here we are trying to aspirate through the superior break under the buccal, and you can see that I inadvertently get a small flap of the retinal margin, and I do a reflux. But just because we were on air fluid exchange, when I do the reflux, instead of the fluid coming out, the first thing which comes out is an air bubble which actually kind of elevated that area, and you wonder why it came from. But because in the tubings there was a small pocket of air bubble which was there from the air fluid exchange, it had to come off. So you could face certain situations like these during vitrectomy, but you can see how easily it can be rectified. It's no more like if you just inadvertently take something off the retina, you are stuck with it, or you'll make a big break. The machines today, you just press proportional reflux, it just goes. You don't have the burnt finger reflex. Just stay there, don't get alarmed, press reflux, instantly it lets go of that tissue, and you're pretty much safe without creating any damage which could worsen the situation. This is a high myopic detachment with some PVR changes where you can see here. In these cases it's difficult to predict the breaks because sometimes they have central breaks and they have peripheral breaks, and they don't do very well without doing a vitrectomy or also putting oil inside. So this is a typical situation of a high myopic. You can also see that I put a buckle in this situation here because I do prefer, wherever I see PVR present already and in cases where we don't find breaks to begin with, I think it's always a good idea to have a buckle. So buckle is important because it's supporting. During surgery you might be able to settle most retinas, but what happens to them in the long run is also based on having a support of buckle, especially in PVR cases. In the fresh cases, of course, it's a very debatable area, and with the new technology we are slowly getting confidence of not putting buckles in a lot of these cases as well. Now this is a situation where there is a detachment with an early macular pucker that you can see, and here the hyaloid is attached, and you can see that I start beginning to pull on the hyaloid, and you can see the movement of how the tissue responds and slowly starts to peel off. And my aim is that I'll remove the hyaloid and then go and take care of the pucker and then take care of the detachment. But you can see that actually as soon as the hyaloid has come off, the pucker has also come off with the hyaloid itself. So what was the pucker is actually now a part of the hyaloid, because we all know that the hyaloid is responsible to act as a scaffold and form the puckering. So at times you'll be surprised how easily things move depending on the adhesion of these membranes on the retina. But this is another situation where there is some thickening of the macular area, and here you want to make sure that this wrinkling which you see is because of a thick membrane or an ILM which is thickened. And here again, these procedures I always do under high mag of a plano concave lens, because it's not possible to do them under a wide field visualization. And you can see that the glistening thin parchment like membrane it can be identified and can be removed, which would remove that subtle traction which invariably leads to PVR in the long term or a pucker in the long term. But mind you, I don't think it's necessary to remove ILM from all the detachments that you do vitrectomy for. Only if you find there is a mild thickening or a puckering is where I would go and then explore under high mag if I feel the patient needs it. This is another such patient. This patient actually had a detachment following acute retinal necrosis once it had resolved, and then had central break somewhere here and a small traction which developed. So you can see that previously has been lasered extensively, but now had developed a detachment due to a central break somewhere here. Now here there is a slight traction on the macular area. So here again, as you would see, after removing the vitreous, we are removing this subtle membrane which could be a mix and match of a membrane or an ILM or at times just a membrane. So you do need to remove whatever you feel is looking abnormal in that area. Otherwise, you can put the retina back on table, but you'll end up with a macular pucker after a month or two, and then you might have to go back in for those reasons alone. So here you've done the removal, and after that you do an endo drainage through the break here. There is another small break here, and then of course do an adequate laser to these cases. This is again a situation of a PVR which will invariably require sort of a vitrectomy. Cannot be taken care of with in a buccal situation. The aim is to, of course, do a very good cleanup in these cases. Not go into the details, but you can see that each of these membranes have to be explored and removed. The perfluorocarbons has amazing help in these cases because it helps you assess the amount of traction at any given point. It acts as the third hand. It keeps telling you where you have released the traction and where you still have traction, which is going on in some form. This is a case of a giant tear. Again, a situation which definitely requires a vitrectomy. Classic tears would be dealt with in this form, where you remove vitreous as much as possible, make the tear freely mobile. There should not be any adhesions. Clean up all the periphery, also the peripheral margin of the tear which you see here. Then perfluorocarbon is the most handy tool to make sure that you flattened it well, and you clean up further, and then do a very good laser and then an exchange. So this is how classically a giant tear would be treated. This is a colobomatous situation, and coincidentally this one has a giant tear along with coloboma. So even normal colobomas, one would undertake a vitrectomy, because we do know that the failure rate of buccals is high, although there are cases, if you can identify very good specific peripheral breaks, they can do well with the buccal, but a lot of them have breaks within the coloboma, and they would fail. They need a vitrectomy, they need oil, and they need a good laser to the edges of the colobomatous area after you've done. So here again, nothing changes. Like a giant tear, the case which I showed you previously, the same way. Aim is to free all the margins, then put perfluorocarbon, which allows you to assess the situation. Do a good laser where you would spare the supposed macular area. This is the area that you would spare, but otherwise you would do a good laser to all the rest of the area, right down to the periphery in these cases, and this is just the immediate post-op. This is a case of a giant tear where there is a thickening on the macula and there is a PVD which has not occurred. So you can see that in such a case at times it can be difficult, although in this particular case it was easy. I was anticipating if it doesn't come off, I'll have to use perfluorocarbon and first stabilize and do it, but you can see those halos came off easily. So even in these cases you can use triamcinolone to your benefit, and then as soon as I finish the hyaloid, I see that the triamcinolone has stained a certain area, which tells me that there is a thickening of a membrane there. So I was not planning to go and explore it, but because the triamcinolone showed this sprinkled area which was over a thin membrane, it's better to go and remove it. So there are these new things that we are learning by using all these. Triamcinolone is changed a lot for us, and I think even now I keep modifying my approaches based on what I see inside. I go with a certain thing in my mind, but at times I get surprised as to what's inside, and then you go and clean. So triamcinolone is a good idea to be used for a lot of these detachment cases, especially where there is no pre-existing hyaloid which is removed. Now this is a case of a giant tear where there is a lot of cystic changes which suggest chronicity to some extent. You do see some thickening here, and of course we do the same approach, but you can see that even after flattening there is so much thickening here. I'm trying to pull and kind of iron it out to some extent before I decide that I might need to cut some areas because they might be stiff. So here you can see that I put perfluorocarbon up to here, but there is a certain stiffness here which I know that the perfluorocarbon, if I keep putting, would go behind. So I make a small retinectomy, reassess. Again, I feel that this area is still not responded to what I cut, so I'm putting some diathermy and relaxing it a bit more at this stage. And then the flattening is better, and you can see that now it's gone back. So in every approach you might need to change the way that you plan these things in. This is a situation which actually has PVR, but also has an IOL which was inside and then had a detachment. So you can see that first the IOL had gone and stuck right at inferior 6 o'clock. So now that we've cleaned up some vitreous, put some perfluorocarbon, you can see that it has started to float up and has come back to the superior area. And then after that we first remove it. And then go in and you open up and you see that there is a lot of puckering and in that area which needs to be taken care of. So again, that is done in high mag view. So these are some of the complex cases where vitrectomy would be the only approach indicated for such a situation. So these are examples of some of the situations. As I said at the beginning of my talk, I'm not here to debate about buckle versus vitrectomy, nor is Dr. Muralidhar, nor is the course intended to do that. There is a place for vitrectomy, there is a place for buckling. Whether we like it or not, buckling is going down in numbers. We all are doing less buckles as compared to what we used to do. It's related to a lot of things, advances, safety, also that the new fellowship programs, it's difficult to train more and more fellows with a good experience of buckling, so visualization systems have improved. So we cannot deny the fact that we are all going to be dealing with more vitrectomies for the same cases that we might have gotten away with a simple buckle. So this is what was our small experience with using vitrectomy. The house is open in case we have time for some questions. We could do that at this stage. Thank you very much.